Hi, my name is Helen Noble, and I worked with Dr. Felipe Vega and Dr. Lacey Lagrone on our research barriers and facilitators to answering clinical questions in the Americas, where we completed a cross-sectional study of trauma care providers. So, up to 50% of patients in the US receive non evidence based care, but practicing using evidence can decrease length of hospital stay and also decrease risk adjusted mortality rates in hospitals. And to provide evidence based care, providers follow the sequence of ask, acquire, appraise, apply, and assess. Trauma providers experience many barriers to completing this framework to be able to really provide evidence based care. So, to sort of delve into this framework, the first step is figuring out how to ask your question correctly. And the commonly known acronym for this is PICO, for population, intervention, comparison, and outcome. There's some other acronyms too, but this is the most well known. And while many providers know this outline, it's not really widespread to the majority of providers globally. The next step is acquiring information. There are a few barriers, and I think one of the most crippling barriers is the cost. One article costs about $30 US, and institutions pay multi-million dollar contracts each year for access behind paywalls. Also, since English is the main language in which most scientific articles are published, providers who aren't fluent can use Google Translate or other services, or maybe they just don't acquire the information. Google Translate has been shown to be more successful in translating between Spanish and English than between other languages like Mandarin, for example, but it still presents a small opportunity for potential harm in clinical settings. So, if a trauma provider can overcome the language and cost barriers and actually acquire the information, they may not have the tools still to appraise the methods and results for their clinical circumstances. Studies have shown a lack of education in appraising primary literature, mostly because this education requires hours of training, and those hours prevent already time strapped surgeons from appraising literature to guide their practice. So, our question coming into this study was, what factors influence trauma providers as they acquire and apply answers to their clinical questions? And then we also asked a sub question about whether or not providers were interested in learning the appraisal step of the evidence based medicine framework. So, we invited all 619 active Pan American Trauma Society members via email and Facebook to participate in this 23 question REDCap survey. They could answer it in English, Spanish, or Portuguese. It asked about participant perception of language barriers, including English reading comprehension and translation quality of literature. It also included 5 knowledge questions that were designed to assess the participants' ability to acquire information on common and life-saving clinical scenarios found in international guidelines for sepsis and appendicitis. This information was relevant across resource settings, and it had also been updated in the past 4 years. Our survey also asked participants about their confidence in evidence-based practice and their interest in learning more about research skills and applying literature to clinical practice. So 108 participants from 21 countries finished the survey. The majority of participants were general surgeons over 45 years old in upper middle income countries working at urban public hospitals with fewer than 300 beds. And you can see the breakdown of our demographics here in this table as well. Our analysis on language showed that 38% of participants reported their English reading comprehension as less than or equal to limited working proficiency. 51 reported professional proficiency English, and 11% said they were native English speakers. Lower English reading comprehension was associated with a higher frequency of reported uncertainty in clinical care, and also related to decreased confidence in interpreting and applying medical literature to clinical practice. In selecting multiple ways to translate clinical resources, most participants used Google Translate or didn't need translation services because they reported understanding the language of the published research. Other participants, around 8%, said that they use colleagues or other translation services for help. and 19% of participants felt that language competency was a barrier to their evidence-based clinical practice. Moving on to resources, most participants were in general unable to answer a clinical question at least monthly using all available resources to them. When we asked them to select their top 3 resources for addressing uncertainty in clinical care, 76 chose guidelines, 61% chose peer-reviewed journal articles, 49% chose meta-analyses, and 42% chose point-of-care information summaries like UpToDate or Dynamed. And then you can also see how this compares to our knowledge questions, the resources that they use to answer those for sepsis and appendicitis in this table here. And for knowledge, we saw that 91% of participants reported having uncertainty at least monthly about any aspect of clinical care they provide, with the remainder denying ever having clinical uncertainty. And you can see the comparison between these two groups in the table here. Most people with no clinical uncertainty were older providers with more experience. A greater percentage of them answered all of the knowledge questions correctly. And then we also asked providers what their patient load was each week because we wanted to connect this patient load with knowledge questions answered correctly. And for the participants who answered at least one knowledge question incorrectly, we added up their weekly patient load and saw that this is 4,795 to over 7,692 patients every week. These patients are patients who could be impacted by compromised practice if providers weren't able to apply evidence to clinical questions. So these are the variables impacting knowledge score when we did our multivariate linear regression. After adjusting for the variables seen in this table, age and country income level were significantly associated with lower and higher knowledge score respectively. So as age increases between predefined categories, knowledge score decreased by 0.3 of the total 5 points. And practicing in a high income country as compared to a low middle income country increased knowledge score by 0.4 out of 5. And then finally, to answer our sub-question for this study, our results show that the majority of participants reported feeling confident about applying literature to their clinical practice and also were interested in learning to conduct research to answer their clinical questions. They also were really interested in learning to appraise and apply existing evidence to their clinical practice. So the study did have some limitations. It was, of course, a voluntary survey that may overrepresent trauma providers from a specific demographic who are engaged in an academic society, obviously interested in participating in this electronic survey, maybe interested in the topic of evidence-based practice. We also use guidelines that are deeply rooted in evidence, and some participants may not have needed resources to answer the survey knowledge questions. Even though we instructed participants to do so, some may not have used all resources available to them, so knowledge might actually reflect motivation to participate in the study more than actual access or appraisal opportunities. Finally, we wrote the survey knowledge questions for applicability across resource settings, but our results might reflect some uncaptured distinction and acceptable practice patterns that vary by country income level. So for our conclusions, on the whole, trauma care providers felt they did have adequate access to resources to address their clinical uncertainties, and they were also confident in their ability to interpret and apply those resources to their clinical practice. But most did endorse difficulty resolving some clinical questions even when using all resources available to them. And most also answered at least one survey knowledge question incorrectly, which corresponded to thousands of patients impacted weekly by compromised provider practice. This discord might indicate an inherent uncertainty in medicine, and it also kind of relates to the fact that there is less and less funding, particularly by the NIH, for surgical or trauma research. And the NIH doesn't have any surgical or trauma center dedicated to research in these areas. So without incentives to produce research or to guide practice, the gap between the available resources and the provider ability to answer clinical questions will widen. We also saw that participants believed their translation services, when required, were sufficient for their clinical practice, but participants with lower English reading comprehension also did report higher uncertainty in clinical care and lower confidence in interpreting and applying literature to their practice. And this can show that even with translation tools, language is still a barrier to practicing evidence based medicine. Those who reported no uncertainty in their clinical care were mostly older, more experienced trauma providers. But interestingly, when holding other variables constant, our analysis showed that increased age significantly correlated with decreased knowledge score. Age correlates with more time away from academia and lower technology literacy rates, which makes it more difficult for these providers to access the latest evidence. Perhaps for more senior providers and others less likely to endorse uncertainty in their clinical practice, education of the rapidity of evidence advancement may normalize clinical uncertainty and also remove a cognitive barrier to evidence based practice. And then, even though the guidelines we used were free and open to everyone online, we saw that a lower income level of the country of the provider correlated to lower knowledge scores. So, there might be more complex barriers that are still associated with financial resources, even with open access information that we couldn't uncover in this study. And this kind of leads us into future research. Future research, I think we really want to uncover ways to decrease the linguistic barrier to resource acquisition and application. We also want to customize interventions to address barriers unique to various provider groups, such as more advanced providers. And we saw that the guidelines we used to create knowledge questions were free to all, but lower country income levels still negatively impacted the knowledge score. So we think it would benefit providers' evidence-based practice for more research to uncover why that is. And then here are the references that we used. And I'm open to take any questions now.